Alrighty, let's get started. So on behalf of Stanford Medicine's LGBTQ plus health department, the San Mateo County Pride Center, and the Cardinal Free Clinics, it is my pleasure to introduce our guest speaker today, Jay Liu. Jay Liu, who uses they, them pronouns, is a fourth-year medical student at Stanford University with a passion for community health, medical education, and whole-person collaborative approaches to care throughout the lifespan, particularly as it applies to underserved patient populations. A computational biochemist and by training, they were inspired to pursue a medical career after experiencing the transformative power of the LGBTQ plus community care. Since matriculating at Stanford as an undergrad in 2016, they've explored what it means to create healing spaces through various roles, including serving as a Trans Lifeline operator, being the co-host of Stanford's undergraduate and graduate trans and support groups, co-manager of the Sexual and Reproductive Health Division of the Cardinal Free Clinics, a PrEP Navigator, a Weiland Health Associate, and Co-Chair of LGBTQ-Meds. In the upcoming year, they will be applying to residency positions in family medicine. So this seminar tonight will explore aging in a transgender or gender non-conforming body. And there are a few potentially sensitive topics that will be discussed tonight, which Jay will go over soon. So with that being said, I'd love to give a very, very warm welcome to Jay and thank them so much for presenting this afternoon.
Thank you so much, Trish. And thank you everyone too for being here and for taking the time out of your day to listen to what I think is a really important topic that is not discussed, unfortunately, too often in the sphere of transgender care. And that's how to care for aging TGNC or trans and gender nonconforming older adults. I am aware that this talk is kind of like an open session where we have kind of health professionals and providers in the room with us, as well as potentially community members. I've tried to kind of make this talk something where anyone can take something away, regardless of your background, medical or otherwise. I will be focusing more on the medical aspect just because of the intended audience. But if anything, I guess like medical terminology stuff that doesn't seem too clear or you have more questions about, I am always happy to take questions or clarify further. And I definitely want this to be a collaborative and engaging discussion. So feel free to speak up and interrupt me at any time. All right, with that being said, I'm going to get started. Also, I just want to quickly give credit for all the amazing photographs that are going to show up throughout this presentation. These were works from Jess T. Dugan's project To Survive on the Shore, which is a photography project that integrated interviews and candid shots of trans and gender nonconforming older adults. And we don't see these pictures all the time in the media. And so I'm so grateful that there is a project out there that showcases these lives. And I highly encourage anyone who is interested in reading those interviews and looking at even more amazing pictures to check out Jess's work. All right, we are in virtual space, but I want to do a line acknowledgement in the setting of myself as a person who is coming from the Stanford University medical enterprise. I acknowledge that Stanford and its affiliated medical institutions reside on the traditional, ancestral, and unceded lands of the Muwekma Ohlone tribe. As a member of the medical and academic community myself, I recognize the legacy of colonization and its ongoing impacts on Indigenous health, access, and well-being. The Muwekma Ohlone people have cared for this land for thousands of years and continue to be the leaders in efforts to restore their sovereignty, culture, and stability. In my role as a medical student, I affirm my responsibility to address the historical and present-day health inequities affecting Indigenous folks. And that includes listening to and amplifying Native voices in medical education, research, and care, and working in partnership with communities to build more just and inclusive systems. I also want to ground this talk in my own personal positionality. I come to this work as a queer, non-binary Asian American person living in a body that's currently thin and physically able. I am shaped by access to higher education and the privileges that affords, and I hold space for the contradictions of being both marginalized and resourced. I strive to use my position of power to advocate for justice for the communities that I both learn from and serve. And I have a few suggested ground rules in case this does become more of a conversation, which I'm not going to go over right now in too much detail, but we can always revisit this slide. One final point before I get started is I want to clarify some acronyms that I will be using throughout the presentation. TGNC is a term that I use often to refer to folks who kind of very broadly identify as trans and or gender nonconforming. I choose to use this term since it seems to pop up in the medical literature as one of the preferred or more preferred ways to speak about this population. So I kind of adapted that language as well. When I say HRT, I'm referring to hormone replacement therapy and specifically gender affirming hormone replacement therapy. And then finally, when I use the term LGB, again, that's also a term that kind of shows up in literature. I'm referring to folks who identify as lesbian, gay, or bisexual. And even though there can be overlap between the TGNC community and the LGBT community, in a lot of studies, they tend to kind of separate these two populations. And so the context in which LGB is going to be used in this talk will also be referring to a distinct population that is not necessarily overlapping with the TGNC one, even though we know in real life that that's not actually how it works. Okay. All right, so I'm going to get started with the first part of my talk. I want to quickly introduce the concept of authentic aging, since it is part of the title of the talk, and I want to be able to ground us as well in why this conversation and why your attendance today at this talk really matters. So in short, this is the issue. Trans people have significantly higher rates of mortality at nearly every age than non-trans people. And this is from a study that encompassed a pretty large group of folks. Essentially, it pulled data from anyone who was enrolled in private insurance or Medicare Advantage plans from 2011 to 2019, and they kind of just tracked their mortality. Why do trans people tend to experience a higher mortality rate? A lot of the times, studies have attributed this to the increased allostatic load that trans people face in day-to-day life. And when I say allostatic load, that refers to the stigma and discrimination that disrupts transgender folks' access to resources, social relationships, and coping behaviors. And all those three things in turn can affect their health in the long term. Adding to the problem, invisibilization of TGNC older adults as they age contributes to this problem because often the trans people we think about in healthcare are individuals from a younger demographic. And as a result, we don't design systems of aging care around the needs of older trans folks. We don't do the research to end up with good evidence-based guidelines to determine how best to care for these folks medically as they age. And not enough LGBTQ plus community spaces or programming options are really directed towards or built to be inclusive of older adults. What I want to ultimately kind of have folks walking away from the talk knowing is that we need to recognize that TGNC older adults do exist. And we need to start designing systems of care that are inclusive of them. And that is one big way that we as healthcare providers can be working to help close this mortality gap. In the setting of a field in which there is not a whole lot of research currently existing on best care practices, one way I like to think about how to approach gender affirming elder care is through the lens of authentic aging. So authentic aging essentially means it is essentially a framework to describe how to approach elder care that focuses on honoring an individual's identity, history, and their body over time. And rather than kind of taking a one-size-fits-all approach to healthcare, it emphasizes flexibility and autonomy when working with patients and encourages active collaboration between patients and providers in order to make healthcare decisions. Again, this is really important to think about in light of the fact that we have very little evidence-based research currently to guide us when it comes to making medical decisions for TGNC folks. And so in all aspects of care, flexibility, collaboration, and autonomy are key. So with this in mind, here are the things that we will be roughly covering, or I hope to roughly cover today. We have gone through a section on authentic aging, In the next section, I will work on kind of going over a little bit about TGNC history and intersectionality, so we have some context before moving into the rest of the talk. The bulk of the talk will focus on aging into transition, or kind of like tips for medical considerations that might be relevant to older TGNC adults. And for this, I will be focusing specifically on gender-affirming hormone therapy and sexual health. I will also be touching on the emotional and social well-being of older TGNC adults and identifying areas of growth. And then finally, I will end on ideas for making systems more affirming for older TGNC adults and an opportunity to do some reflection on what aging authentically means to you personally. Okay. So my first section is on contextualizing aging and gender. I'd like to kind of do a little bit of a history deep dive on who our TGNC elders are. So just to start off, I do have the caveat that in the trans community, eldership is not necessarily a number. Sometimes people who have transitioned or been out only a few years attain elder status within their community in recognition of their unique lived experiences and extensive perspective. However, for the sake of the presentation, when I refer to a TGNC elder or a TGNC older adult, I will be referring to people age 45 plus, given their current relative lack of representation in the mainstream media and in our medical research. So when we think about people who are 45 plus, we're kind of looking at the people in this generation above here. Really briefly, when we consider people who are in their 90s right now, they're people who lived through World War II and the Great Depression. People who are currently between the ages of 75 to 89 lived through a period when medical and legal institutions defined homosexuality as a perversion that was treatable by conversion therapy. People who are in their 60s and mid 70s lived through the civil rights era and saw a period when homosexuality was finally removed from the DSM thanks to the work of LGBTQ plus activists. And then finally, folks who are age 45 to 59 are people who have lived through the AIDS epidemic and might be approaching their sexual health care very much from that lens of having a lot of fear around the illness and about the impact that it has had on the community. There is a whole other way, other than age, to look at trans eldership that kind of takes the perspective of what exposures that people have access to when they were kind of like of the general age to undergo transition, assuming that transition for most people kind of occurs like in their maybe 20s, 30s, 40s. And by transition, I mean not only kind of pursuing a medical transition, but also possibly exploring and coming to terms with a transgender identity and undergoing a social transition as well. And so when you kind of try to break it down by transition timeline, when we work with people aged 65 to 95, we're looking at people who transitioned at a time when almost no information was available about how to be trans and like what being trans meant. These are people who may never have had an opportunity to connect with the trans community. When we work with people ages 45 to 65, we're looking at people who maybe transitioned at a time when they had more access to the internet. And so they were able to share and they're able to privately ask questions and access information on how to transition. But trans community at this time was also more centered around major cities. And so they may also have experienced more community-based isolation. The current generation that we're currently in, Generation 3, are folks aged less than 45. And these are folks who have had a lot more access to trans community thanks to social media, YouTube, things like that. But these are folks who are also currently facing a huge wave of anti-trans backlash and legislation during a period when they may be wanting to undergo transition. Okay. And then kind of going off of the age-based kind of like historical context aside, I also wanted to mention that another factor we want to consider when working with our older trans folks is that different parts of the trans community are going to be facing different challenges based on identities that they might hold. And we kind of refer to this concept by the term intersectionality, which is a term coined by scholar Kimberly Crenshaw in 1989 to describe the oppression faced by Black women. And it essentially refers to the fact that marginalization and in turn health outcomes can occur along multiple axes of identity. To illustrate that, I have data from also an insurance analysis of mortality rates in trans communities compared to cis communities, finding that compared to cisgender folks and transmasculine and non-binary folks, actually, trans feminine and non-binary folks assigned male at birth were consistently shown to have kind of the worst mortality outcomes, unfortunately. And I hope this graph is readable. I tried to, the original one was in black and white, so I tried to do some heavy editing. But the graph on the left side of the screen compares individuals identifying as Black who are either trans feminine, transmasculine, cisgender, cisgender man or cisgender woman. And so this is kind of like within the Black cohort, and then this is like a separate graph for the white cohort. This is kind of a phenomenon that is commonly observed that we refer to as transmisogyny, which refers to the fact that trans femme folks are existing at the intersection of stigma against both the transgender identity and sexism as well. Adding to that, we also see a comparison between mortality rates for trans folks when it is stratified more by race. And so whereas in the previous graphs, we are comparing mortality rates of trans populations to their cisgender counterparts. In this graph, we're only looking at trans populations. And what this graph is trying to illustrate is that compared to kind of trans people broadly as a whole, Black, trans femme, and non-binary folks assigned male at birth tend to exhibit worse mortality rates. And again, this is posited as a consequence of them existing in the intersection of transphobia, sexism, and racism. And this is kind of a concept we broadly refer to as transmisogynoir. Another intersectional identity that a lot of trans people carry that we want to consider when working with them is that people who are trans, older adults, are actually far more likely to be military veterans. 41% of trans older adults identify as a veteran, according to a survey completed by SAGE in 2023. And this is compared to 1% of the general population and 24% of the LGBT older adult population. From what we know of working with veterans and trans military veterans in particular, we know that they can tend to have a higher rate of experiencing HIV, combat-based trauma, and military sexual assault. And so when we're working with our trans older adults, one thing that we want to be asking is whether they do have a service history, and if so, whether any of these topics are things of concern to them that they would want to discuss further. I want to note that there are lots of identities that I did not go over that are shared amongst the transgender population. Unfortunately, there is still limited research on the experiences of this very diverse community. But I do want to point out a project that was recently completed by UC Berkeley Center for the Advanced Study of Aging. They conducted focus groups with 208 LGBTQ adults who all identified as, being like older and aging within the LGBTQ community. And they produced some really awesome resources and handouts that kind of summarize major challenges and strengths that are exhibited by these community members. And they go into kind of a lot more detail as it comes to intersectionality than I've been able to touch on in this talk alone. So I highly encourage you to check that out if you're looking for a fun read. Okay. I'm going to pause here real quick for any questions because I'm going to dive into the bulk of the presentation now, and we'll kind of descend more into medical land. But if there are any questions that I can help answer before we kind of move into that section. Okay, that is so valid. If any questions do come up, feel free to add them in the chat or just interrupt me. I think this next section is the most fun anyway. All right, so aging into transition. I want to go over some medical points that we might want to be aware of when working with our trans older adults. One caveat of this section is again kind of like the lack of research. And so a lot of the tips that I will be going into are kind of the things that I have picked up over time as I have worked with experienced providers like Dr. Lania Kea when it comes to the care of older adults. We are definitely still lacking in a lot of the research necessary to establish good evidence-based guidelines. But these are potentially some things to be more aware of as you think about how to adapt a standard HRT or sexual health care plan for your TGNC older adult friend or patient. So in this section, I will touch on describing HRT, sexual health, supporting mental health, and navigating cognitive changes. But before I do, I want to quickly note why focusing on HRT is especially relevant to the trans older adult community. Trans older adults can and do start HRT later in life. It is never too late to transition, and many people end up changing their minds about transitioning as they get older and their circumstances change. So as people get older, they experience changes in their family of origin. Parents might be passing away, adult children might be leaving home, they might be navigating a divorce with a previously unsupportive spouse. And so they may feel kind of more free and flexible to make those changes and transitioning choices that they may have wanted to make when they were younger. People are also experiencing retirement at this point, so they no longer have to deal theoretically with telling their coworkers that they're trans or facing job discrimination. And they also might be confronting more serious health changes or medical events that might make them think, okay, maybe this is my last chance to live my life authentically. Maybe this is my last chance to experience a transition. And so a lot of people end up showing up being like, hey, I'm an older adult, but I do want to think about HRT. And so it's good to kind of constantly revisit conversations with patients about their personal hopes, plans, and goals surrounding their gender transition in case the answers do start to change. We do find that happens. Across the ages, transitioning is consistently found to be a liberating experience that brings happiness, self-confidence, and connection, as well as improved mental health. However, of course, there's limited research exploring the impact of aging on gender-affirming interventions. And as we work with older populations, we know that as people end up on more and more medications, this kind of like medication bloat, which we refer to as with the term polypharmacy, can pose additional challenges. And so this is definitely an area in which patient-centered collaborative decision-making with the knowledgeable and informed provider is very, very important. Okay, I'm going to do testosterone first. So I have kind of like reproduced on the screen here what we tend to think of as our standard protocol for prescribing testosterone when it comes to gender-affirming HRT. And I am going to go over some points that we might want to be more aware of when we're working with our older populations. So first, the standard mid-cycle goal that we set for testosterone is between 500 to 800 nanograms per deciliter. However, we do know that testosterone naturally declines with age, even in cis men, at a rate of 1% a year after age 30. And we kind of refer to this process with the term andropause. And so when we work with older adults, let's see, sorry. Okay, sorry, yes, I was just working on my animations. Okay, so when we work with older adults, we might want to consider adjusting the mid-cycle goal range according to your patient's age, preferences for masculinization, and overall health. This can also be important when we start considering the impact that testosterone might have on heart health. Multiple meta-analyses of the literature generally show no increased risk of cardiovascular events, such as MI or stroke, in the trans-masc population when compared to the general population. That being said, those studies have all been done on younger folks, and newer studies are coming out that are suggesting that actually older trans-masc folks may be demonstrating increased risk of these events. And so in light of this, it's particularly important to monitor for those lipid imbalances and to consider the role that additional medications might be able to play in supporting heart health when prescribing testosterone, such as our statins and aspirins. It's also important to note that testosterone is protective against generally bone loss. However, if we're thinking about a regimen that lowers testosterone dose, if we're thinking about taking a break from HRT for whatever reason, or if my transmass patient has undergone an oophorectomy, it's important to also keep up with the DEXA scan so we can make sure we are proactively keeping up with our bone health. And then finally, when in terms of cancer screening, having a good organ inventory and keeping that up is really crucial when it comes to being able to offer people the right screening. Testosterone, some studies show that it may be protective against breast cancer long term. However, the recommendation right now is to keep screening even after someone has received top surgery because they still have some breast tissue on them. And to, again, continue to consider other cancer screening options depending on whether they still have organs like a cervix. Okay. Yeah, sorry, there goes my bone health point. Okay. And then when it comes to prescribing estrogen, these are the typical things that I look out for. So this is, again, kind of the standard suggested regimen for prescribing estrogen HRT. And then there are a few modifications that we want to think about making when we're working with older adults. So just like, let me go back, I'm sorry. Just like for testosterone, estrogen naturally declines with age in our cis women population, and this is what we refer to as menopause. And so even though our mid-cycle goal range tends to be 100 to 200 nanograms per deciliter with our trans femme folks, we might consider lowering that dose, especially if we're concerned about heart disease. This is really, really important, even more so than when working with trans mass folks, because the bulk of existing research, even when it is conducted on younger folks, show that the risk of MIs and strokes tend to be higher amongst the trans femme population compared to the trans mass population. And this is generally regarded to be due to either the route, dose, and type of estrogen, with higher doses of estrogen being correlated to a higher risk of adverse cardiovascular events. With that being said, again, monitoring for those lipid imbalances is really important. And considering the role of statins and aspirins to help mitigate heart disease risk factors is really important when working with this population. Interestingly enough, transdermal estrogen patches have not been found to be associated with an increased risk of blood clots, unlike oral forms. And so this might be a really good option to consider when starting an older person with some of these heart disease risk factors on HRT. Because stroke risk kind of goes up with quantity of dose, in prescribing HRT, as in prescribing many medications, the principle we try to operate by is to start low and go slow, and kind of try to keep people at a dose where they can experience all the effects that they want to be experiencing without kind of inflating their risk higher than it needs to be. And then adjusting overall goal. And then just like for our trans mass goals, maintaining a good organ inventory is crucial, especially if your trans femme patient still has a prostate. We want to be doing that prostate cancer screening. Breast cancer screening is also really interesting in this population. So because breast tissue does develop when we're on estrogen, the typical recommendation is that we start screening folks after they have been on HRT for 5 years, or after they hit age 40 to 45. And then finally, a few points when it comes to prescribing those anti-androgens. Spironolactone is pretty standard, but it's not as great for folks who are experiencing kidney or liver concerns, or who have a heart disease, a heart condition that elevates the risk for cardiac arrhythmia or rhythm issues. And so that's something to note when thinking about the role of anti-androgens and which one to pick. Finasteride as an anti-androgen may play a dual beneficial role if your patient also has benign prostatic hyperplasia, but it has been associated with the rare post-finasteride syndrome that affects approximately 1% of people. And that syndrome comes along with it erectile dysfunction, anxiety, and depression that may or may not be reversible with stopping finasteride. So use it cautiously. And then finally, bicalutamide, which is another anti-androgen option, has been associated rarely, but in some cases with liver abnormalities. And so that might also be something to consider in the context of your person's overall health. Okay, that was a lot of information, but that was kind of the HRT rundown. Do I have any questions at this point?
And
Okay.
folks can feel free to either use the raise hand emoji or type in the chat any questions.
We can also like revisit this at any point if there are any if there's anything that people want to discuss in more detail. Okay, I'm going to move on to another health topic, sexual health. Older adults, just like with HRT, many older adults continue to engage in sexual activity as they age. Don't assume that because someone is old, they're not sexually active. And culturally affirming sexual health care for older adults is known to be a really important aspect of fostering overall health. When we think about how to conduct a comprehensive sexual history, we're typically looking at asking information about the 6 Ps. So that includes partners, practices, past history of STIs, protection from STIs, pregnancy plans, and pleasure. And I'm going to be going over those in a little bit more detail in the following slides. What we have found is that no modifications tend to need to be made to our typical interventions when we think about how to prevent pregnancy, STIs, and HIV. And so going over those really quick, when I kind of approach a sexual health discussion, I try to touch on all 3 of these points. So the first one is, of course, our vaccines. Vaccines are particularly relevant to the LGBTQ population that we might want to consider for our patients, include the Hep A and Hep B vaccines. HPV, if they feel like it's relevant, can be a discussion based on age, especially if you're treating an older adult. And then finally, the Mpox vaccine. In terms of screening tests, we're looking at ordering a gonorrhea and chlamydia test. The standard one is through urine, but we also have oral and rectal swabs, and we want to be making sure that patients receive those if that is relevant to them and their sexual practices. We want to be ordering syphilis tests, HIV tests, and then it's a newer recommendation, but now we are asking providers to screen folks for anal cancer as well, in recognition that HPV can cause cancer both in rectal tissue as well as cervical tissue. And so the anal cancer screening guidelines apply to anyone who is engaging in receptive anal intercourse, anyone who has a rectum. So that includes anyone engaging in oral penetration, toys, or penile penetration. If you are less than 35, so between the ages of 21 to 35, we recommend a digital rectal exam. And the starting age 35, if you're HIV positive, we recommend the anal pap. And then starting age 45, if you're HIV negative, we also recommend the anal pap. And then finally, some quick points about protection, our fun PrEP and DoxyPEP. Yeah, sorry, the anal cancer screening point. Okay, for PrEP, especially when working with an older patient population that might have lived through the AIDS epidemic, we're looking at people who have a lot of trauma around the impact of AIDS on the community and may have a lot of reservations around dating and being sexually active as they get older. It can be very comforting to patients to know that the risk of acquiring HIV on PrEP is around 1% for like, you know, like the I hesitate to use the word least effective because they're all incredibly effective. But even if you're looking at the least effective formulation, the risk of acquiring HIV on PrEP is only about 1%. And if you're looking at any of the other ones, less than 1%. We have kind of 2 different forms of PrEP currently available to us now. I would lean towards picking Truvada, the older PrEP, if someone is more worried about lipid imbalances or heart disease, or about cost, since the old PrEP is a lot cheaper than the new PrEP. And then think about the new PrEP, Descovy, if you are working with a patient who may be more worried about their kidney or bone health. And then our lovely DoxyPEP has shown to be safe in older adults, and so we don't need to adjust prescribing based on age there. Okay. And then I like to also walk through some questions or some tips on taking a sexual history. So I mentioned before the 6 Ps. I'm going to be going over them as we walk through this together. So the first part, of course, in obtaining any kind of history is obtaining consent, especially when we're approaching a sensitive conversation. And so this might look like a statement that goes, may I ask you some questions about your sexual health? This information will help us determine care that best meets your needs. After obtaining consent, we want to determine if your patient is even sexually active. So this includes a question that is broad about the types of sex that you're interested in hearing more about, as some people might not regard, say, oral sex as like a valid form of like sexual activity that warrants discussion in the doctor office. Number 3, we want to ask about partner. So there's our first P. So keep this question broad. How many people have you had sex with in the past year? We also want to know genders of partners. What are the genders of the people you have had sex with in the past year? Then we move on to sexual practices. So the straight up question you can ask is kind of what types of sex do you have? But especially knowing that this tends to be kind of a more sensitive question, and we are working with a population who has a lot higher rates of medical trauma. Sometimes we want to consider contextualizing that question in a discussion about how their answer is going to affect the testing choices that we offer them when it comes to ordering STD and STI testing. We might also want to consider, instead of asking patients straight up, what types of sex do you have? You can kind of give them options when we're considering testing ordering. So for instance, we order a urine test for chlamydia and gonorrhea, but we also have separate swabs for oral, vaginal, and rectal mucosa. So would you like me to order those tests as well? We also want to be assessing their past history of STIs. And again, this is a question that can be perceived as overly intrusive, or like, why do we need to know this information? And we want to be explaining that again, like the information is necessary to order the correct STD and STI tests. So for instance, if someone has been treated for syphilis in the past, we wouldn't want to be reordering the treponema test because that might be falsely positive. So for instance, have you ever tested positive for an infection spread by sex? Did you receive treatment? Those are questions that can help us determine what is the best way to help take care of you. Last couple of P's are about protection, pregnancy plans, and pleasure. And so this is a really broad question that kind of encompasses information about condoms, birth control, PrEP, DoxyPEP. The conversation can go in a lot of different places depending on someone's personal preferences, sexual practices, and personal concerns. And so be prepared to have a fun conversation there. And then finally, a final question about sexual function and pleasure is extremely important. I like to keep this question really open-ended. So what questions or concerns do you have about sexual function or satisfaction? Letting your patient guide you in terms of that discussion. Okay, that was a lot of information. At this point, we are done with the third part of the talk, which is about kind of prescribing considerations to keep in mind when working with older TGNC folks. We covered gender-affirming hormone therapy and sexual health. And I'm going to be transitioning now more into the mental and psychological and brain health side of things. So before I do that, any questions? Okay, great. More time for discussion at the end. Okay. Section 4, social support and belonging. So I'm hoping to kind of focus this one on mental wellness, community, finding belonging throughout life, and also some considerations we might want to be thinking about as people approach end of life. First, I want to start off on mental health with an awareness that older TGNC adults report significantly higher rates of depression compared to LGBT older adults. And so it's really important to screen vigilantly. Older TG adults have been shown to have high rates of suicidal thinking and behavior, with a Swedish study reporting that every third participant had seriously contemplated suicide. And that was a study conducted in 2019. A similar US study conducted in 2011 found that 41% of their TGNC older adult participants had previously attempted suicide. The trans community is historically known for having extremely high levels of resilience. However, for older TGNC adults, we are looking at a community that might be losing members of their community as they get older. And as such, levels of resilience may also tend to decrease with age. It's important to ask for help early and to be aware as a healthcare professional that your effort that you take to support this population and advocate for them, especially when they can no longer advocate for themselves within the healthcare system, is so incredibly important. And to consider referring early and often and connecting patients to community resources, such as SAGE, a group specifically dedicated to advocacy for older LGBTQ plus individuals, as well as the lovely Trans Lifeline, suicide crisis line staffed exclusively by and for the trans community. On the coat ends of mental health and depression, it's also worth noting that depression is a known risk factor for Alzheimer's, and correspondingly, TGNC older adults have been shown to experience higher rates of cognitive impairment, schizophrenia, and Alzheimer's compared to cisgender older adults. It's hypothesized that minority stress plays a significant role in the development of these conditions. TGNC older adults may have specific fears and concerns around cognitive changes and the end-of-life journey, especially when it comes to continuing to be treated with respect and continuing to receive gender-affirming care. One particularly salient quote from a qualitative study of trans older adults who were all kind of thinking about concerns they had moving into end of life, were that participants shared that they were concerned about how their burial processes would be handled, with one participant stating that she worries about how her family is going to bury her and how they're going to show her in her casket. She stated that when I die and I am buried, I would like to be known as the female I have become now. And unfortunately, this is a right that not a lot of trans people can really count on being able to access. One way as providers that we can work on supporting that is to encourage TGNC individuals to prepare very clear advanced directives that contain specific language about how they would like to continue receiving gender-affirming care as they move into later life. And I've spotlighted one community resource that does a really good job walking patients and providers through the process of doing that. For many TGNC older adults, we find that preserving the truth of their transition and gender identity, both at the end of life and after death, is a vital component of their old age planning. And it is particularly important to think about, too, in the context of cognitive changes, as it has also been shown that some TGNC older adults may start to experience more gender fluidity, or some people might prefer to refer to it as gender confusion, as they develop those cognitive changes like dementia later in life. And so if someone's gender identity kind of starts to become more in flux, it can be important to have a conversation early on about how they would like that to be handled. And that can be something that really improves the ability of someone's existing caretakers and providers to treat them with respect and with the knowledge that these were their preferences before they have experienced these cognitive changes. And so I just want to spotlight some phrases from this pamphlet, Planning for Lifelong Care, because I think they're awesome. Some suggestions to add to, we'll start with this one. Some suggestions to add to advanced care directives that pertain specifically to gender-affirming care include this example clause on respectful relations. So it basically states that, as I go through medical care, regardless of what my legal status is in terms of court-ordered name change or gender marker change, I would like to be referred to by this name and to be referred to with these pronouns. Another related clause that speaks directly to dementia treatment includes this one that kind of states, hey, and this is kind of like a more gender fixed approach to it. Regardless of my physical and mental state, I would like the following treatment, maintain this set of gender affirming healthcare practices, and continue to affirm me as this gender. And there are different ways to phrase this depending on how fluid you would like to be as you age. And there are kind of different options in the pamphlet as well for each of these conditions. So again, I highly recommend checking it out. It's a great resource. Touching a little bit as well. Oh, sorry, I'm not sure why I'm skipping these slides, but touching a little bit as well on long-term care. As people age, often another consideration becomes, okay, should I think about enrolling into a long-term care facility, especially if I don't anticipate having a close network of people available to help support me as I get older. And what we have found is that older TGNC adults share many valid safety concerns when it comes to about life in a long-term care facility. In long-term care facilities, we generally see very limited training due, unfortunately, in part to the fact that these facilities rely a lot on the labor of a transient workforce, and so it can be hard to kind of maintain that institutional knowledge. That being said, there's a lot of concern from the trans community about isolation, abuse, lack of affirmative gender, lack of gender affirming practices within the facilities, and also potentially lack of access to HRT in a facility. It is the role of the provider to be aware of a patient's individual preferences and potential coping mechanisms that might arise in the face of these concerns. So some older adults may view strongly that they must complete a quote unquote full surgical or hormonal transition prior to entering long-term care in order to most effectively pass as the gender that they want to be seen as. You may also want to be prepared to field questions about self-euthanasia. That's a topic that's come up in conversations within the community when it comes to surviving or coping with abuse that might happen in long-term care facilities. And that can be a really, really hard conversation to have with folks. But I want to be kind of put on your radar that like this stuff might come up. And it's crucial to kind of know how to navigate that discussion. Some community resources do exist again, and they can be helpful to refer patients to or to look at yourself as a provider. The Transgender Law Center has a really great trans legal survival guide that they've put together that kind of outline your rights as a trans individual in many spheres. And they include things about long-term care and end-of-life planning. So looking specifically at those sections can be helpful when thinking about how to make sure you have the smoothest experience possible when you transition into later life. There is also an LGBTQ equality index that is maintained that lists long-term care facilities that are more friendly for LGBTQ folks. And that is kind of a list that is constantly updated that we can refer to. And then finally, there are technically long-term care ombudsman programs that have individuals acting as advocates for folks who might be experiencing abuse within nursing homes and long-term care facilities. And they can help advocate for trans patients who are having a tough time in those settings. And then finally, I didn't put it here necessarily, but SAGE and Forge are both organizations within the community that work a lot on advocacy for older TGNC adults, and they both offer trainings specifically geared towards long-term care facility staff in case there is a particular center in mind that you want to focus on helping become more trans-friendly. You can always refer them to check out those trainings and to potentially like organize a training on your own. Okay, I want to end on a more positive note, slightly more positive note. Chosen family. In face of all these challenges and changes with aging, chosen families can be a huge source of support for trans people. And so as a healthcare provider, we need to be aware of the fact that different family structures often exist within the TGNC community. And instead of assuming that, say, like someone has a kid or someone has a parent that they can go to for support, ask in those visits, who is most important to you in your life? And keep that question open-ended because the answers may surprise you. And making sure as well for folks who don't have as much access to that community, that you're helping them find a way to connect to a broader community can be really important. Sadly, findings show that 30% of TGNC older adults are currently unsure of who will care for them later in life or during a serious illness. And TGNC older adults are also known to experience more isolation as they age, possibly again due to the fact that a lot of LGBTQ plus community spaces are unfortunately built mainly with younger populations in mind and don't always cater to older folks who might feel like they age out of the community spaces as they start to get older. Social isolation has been shown to have a known adverse effect on cognitive decline. So things we were talking about earlier with Alzheimer's and dementia. A big part of kind of developing a good prevention plan for those conditions includes finding a good community. So in terms of resources we have to that end, again, I'm going to refer back to SAGE. They have a great kind of patient-facing resource to help people design a care plan around times in life when they might be considering undergoing a more involved medical procedure. And that can happen more and more often as people age. And so it includes kind of like aftercare planning, like figuring out how to do that, and like what kinds of questions to ask your surgeon. Things that might kind of more readily come up if you have a stronger like social support system to help you navigate that event. But for someone who feels more isolated from their community, it can be helpful to again have that resource so they make sure they are checking all those boxes when it comes to planning for major medical events. And then Sage and Forge both have resources that they have built to kind of try to connect the older TGNC community with either other members of the older TGNC community or younger members. And they have specific programs that you can sign up for to connect with an older member of the community. And it can be a really positive way to help people, again, like build out their support system and find those people in their life as they start to get older. Okay, a quick summary of everything we've been through. We talked briefly about kind of both physical and mental health considerations to make when caring for older TGNC adults. So in the realm of bone health, our osteoporosis and osteopenia, luckily HRT is not currently shown to have a significant effect, but we want to plan carefully if someone is thinking about taking a pause from HRT, lowering their dose, or undergoing a gender-affirming surgery. For heart health, HRT may have an effect, especially when it comes to working with older adults. And so when we're thinking about a transplant population, we might want to more heavily consider transdermal estrogen options. And we also want to be working to teach patients how to recognize signs and symptoms of cardiovascular events so that they are prepared to respond appropriately, get themselves in the right places if something does happen. We also want to provide compassionate medical and psychological support around minimizing known risk factors, and that applies to both heart health, bone health, mental health, and everything in between. For cancer, it's unclear whether HRT has a strong effect on any of the cancers right now. I would recommend generally screening appropriately according to a good organ inventory that you maintain. For sexual health, practice the 6Ps, offer your vaccines, STI testing, PrEP, and doxy-PEP according to a patient's behaviors, preferences, and overall health. Mental health, ask early and often about someone's sources of support, offer timely referrals to LGBTQ plus affirming providers, as well as community resources. And then finally, when it comes to cognitive changes, engaging in trans-specific advanced care planning discussions can offer a lot of relief for those older community members and allow them to engage in kind of compassionate and relevant medical and psychological planning for end of life. Okay. The final couple of sections I'll be moving through are a lot briefer, and they kind of include on some thoughts on advocacy, inclusive aging, how we can be working together as a community to create those affirming systems for TGNC adults. And so I'm kind of moving a little bit further away from the medical side now.
And Jay, sorry to interrupt,
Yes.
but just to let you know, we're coming up on the hour here.
Okay. Why don't I move through this? I think this is the main thing I want to spotlight here. When this is from, again, Berkeley's project for advanced aging, when we actually kind of talk to our older TGNC folks, the things they really want to receive from their community and from their healthcare providers is, again, to have those accessible and inclusive spaces in which to exist and to be seen as themselves. And so there are lots of things that we can do as providers to try to help create those environments for folks. This is an ongoing discussion that I encourage you to have with people in your department and to have with your friends and coworkers as we work to create those spaces. All right. The final thing I wanted to include was this video.
No me gustan las etiquetas. Yo me siento una
sorry.
mujer muy alegre, muy fabulosa.
We hear it.
Okay. You can hear it? Okay, great. This is a longer video. I'm going to maybe play the first minute and then we can move on to questions, but people are free to kind of come back
Yo
to
nací
this
a lo mejor con
through the
ese
resources.
sentir de sentirme mujer, ¿no? Ya bien se puede decir escrito. Y yo, pues la verdad, me siento muy feliz así. No es fácil ser una chica trans. Yo que tengo 55 años, he tenido experiencias tanto buenas como malas, pero se puede decir que un poquito más malas que buenas. Pero gracias a Dios aquí estamos todavía, luchando por nuestros derechos y nuestras causas. Desgraciadamente soy VIH positiva y soy diagnosticada también con diabetes. Aquí en el área de la Bahía, gracias a Dios nos han dado servicios muy buenos, nomás que un poquito truncados también porque el idioma, como le digo, es un poco incómodo por la cuestión esa también de que a veces nosotros pues en realidad tenemos nuestros nombres originarios de nuestros países, los que nos pusieron nuestros padres, pero a veces uno llega a una clínica, a un hospital y mi nombre es Verónica y tengo una cita y me preguntan, oh, ¿quién es usted? Y le digo yo, Verónica. Dice, pero aquí sale el nombre de tu nombre original que es Hugo. Y le digo yo, sí, pero yo soy una chica transgénero, ya me hice mi cambio de nombre y no he podido cambiar documentos por cuestión de una u otra cosa. Lo ofenden a uno porque pues está viendo la apariencia de una mujer y todo eso. Y sí me molesta un poco porque a veces lo hacen con malicia y yo pienso que en lo particular podrían ser un poquito más accesibles o que los pongan a un poquito más accesibles para que tengan un poquito más de respeto hacia nosotras, porque pues nosotros no estamos haciendo nada malo, simplemente que estamos cambiando nuestra identidad porque así nos sentimos. Una vez me tocó un doctor un poquito grosero conmigo porque yo le comentaba mis dolores, mis quejas y todo eso. Pues como él es mi doctor, yo le decía, doctor, tengo un problema por esto. Y siempre me decía, mire señor, usted tiene este problema porque ya está grande. Eran una respuesta y yo me quedaba así como, bueno, pues ¿qué hago? Que una enfermera.
All right. I'm going to stop this here for time, but I highly encourage you to look at the rest of the video. It's a really great one. I hope what this kind of emphasizes at the very end, I guess, is that even though we went over a lot of kind of involved and complicated stuff when it comes to thinking about the medical care of trans folks, ultimately what we need is kind of that basic respect, is that kind of gender affirming care, and focusing on those fundamental principles, respecting someone's pronouns, honoring someone's gender identity, can come a long way to providing them with the best care that they need as they start to get older. And when approaching those medical decisions, again, working with folks collaboratively to make those decisions together is ultimately how I think we're going to approach this in the long run. Okay.
No me gustan las etiquetas. Yo me siento una mujer muy alegre.
That's the end. The final thing I have is just a QR code where you can kind of get a list of the resources that I refer to in this presentation, as well as my references. And I want to give special thanks to Dr. Benjiwan and Kea, who I've worked with over the past year and learned a lot of these practice tips from. Thank you so much for your time and mentorship. And also thank you to Trish Nova for helping organize this event, and the LGBTQ health department as well, Blaze Wei Chen for helping organize, and really kind of like also bringing up this idea of like giving a presentation focused on older trans folks as something that would be valuable to the community. So So thank you. I really appreciated the opportunity to do more learning myself on this topic and to be here to talk to you all about it today. Okay, that's
Thank
it
you
for
so
me.
much, Jay. Absolutely. And I think I can speak on behalf of the full room and folks who had to hop off a little early that we are holding so much new information in our minds and our hearts. So thank you so much for such a comprehensive presentation around health and older TGNC populations. I really feel like this was incredibly educational. So we really, truly appreciate it. There was one question in the chat that came up regarding sexual health questions. Are these questions we should bring up ourselves as patients to our doctors if they don't ask us? And do you have a way to frame those questions as patients?
That's a great question. I would say from the start, yeah, like if you feel like you have a comfortable enough relationship with your provider where you don't feel like you're in an unsafe place to have that conversation, and you think those topics are important to you in your life, and your provider is not bringing them up, then like 100% like go ahead and bring it up with them. I'm sure that it is something that they hope to be able to talk about, but maybe has just been overlooked due to like time or even sometimes assumptions, unfortunately. Um, and I think one way I would suggest kind of approaching it is to just be as upfront as possible. I have some questions about my sexual health, and yeah, I was hoping that you might have some advice. And then hopefully the conversation can evolve from there. But you know, like your provider should work with you and not against you. And so if it feels like an unsafe space to have that conversation, or if someone is not kind of treating you with the respect that that conversation deserves, uh, it can be helpful to seek a second opinion or to look for a different patient-provider relationship.
Absolutely. I was just about to jokingly say, call us up here at the LGBTQ plus health program, but actually, like, please do if we can offer a second opinion and if we can help improve and better your health. Absolutely. And I'll just read this FYI in the chat loud because I think this is great. FYI for family and support for TGNC patients, California has a bill up this year that would extend paid family leave to chosen family. SB Senate Bill 590 from Durazo, inclusive paid family leave. Not yet law, but promising as it passed the Assembly Insurance Committee 14-0, no opposition on July 9th. So a little bit of a glimmer of hope for us in this chaotic circumstance and environment we continue to navigate together.
That's amazing. Thank you for bringing that up. I didn't know that, and that's awesome. I will be looking into it after this.
Absolutely.
Yes. I can stay for a little bit if anyone wants to ask any other questions, but I also understand that we are over the hour, so if anyone has to leave, also feel free to do that. I am also available at that email address if anyone ever wants to contact me or reach out.
Wonderful. Well, thank you so much, Jay. We'll pause the recording at this point, but just want to reiterate again how much we appreciate this presentation and how much this has really served us. As you mentioned, older TGNC adults are not too often highlighted and talked about. And so this has been a really wonderful educational opportunity, even for us who interact with LGBTQ plus health every day. So thank you so much. We'll go ahead and pause the recording at this point, but we'll stay on for a few minutes in case folks have any remaining questions. Thanks so much for being here.